introduce you. Hello, ladies and gentlemen. I see Benjamin Peterson, Luis Brasino, Marilyn Wamalwa, and Michael Kemp so far. Guys, you'll need to keep your microphones off unless you have a question, but then you can unmute your microphone and get Dr. Frame's attention, ask any questions that you have. Be sure to remute your microphone once that's done so that your ambient noise around you doesn't disturb everyone else. But I'd like to introduce you to your lead medical director, Dr. James Frame, if you haven't been in one of these before. And looks like we got an interesting topic tonight. So that having been said, I'm going to mute my microphone and turn it over to you, Doc.
Well, thank you very much, Jane. Well, welcome everybody, and I'm glad that you're here this evening. Jane and I were just talking about, you may have chimed in on it, the National Registry for this cycle, the 2020-2021 cycle. Emphasis is going to be on cardiac arrhythmia, specifically stable and unstable SVTs, narrow and wide complex SVTs, and regularly and irregular SVTs as well. More often than not, you got one from each of those three categories rolled all into one arrhythmia. For instance, atrial fibrillation rapid response. More times than not, it's narrow complex. It's irregular, and the only other determination you have to make is, does the patient have altered mental status, low blood pressure, shortness of breath, difficulty breathing, or any other criteria that would make the arrhythmia unstable? Previously, and we'll have a chance to talk about it this year as well, it's on one of the up and coming lectures that I have, but a person that presents with shortness of breath, difficulty breathing, and altered mental status with a heart rate of 180 is considered unstable. And subsequently, what protocols would call for would be to sedate the patient, airway support, oxygenation, heart monitor, obviously, and then initiate a cardioversion. What we've been talking about, what we will talk about here briefly, is the supraventricular tachycardia as it relates to amiodarone. Now, it's a pretty refined topic. It's only going to account between 1 and 4 questions. I can assure you the amiodarone 300 milligram IV bolus for VFib, pulseless VTach, or Torsad is going to be tested. That's a given. It's on every single National Registry exam. Know when it occurs. We'll go over it here in a few minutes. As far as the algorithm is concerned, usually given after the first epi. As we get more into the lecture, we can touch base with that a little bit, but amiodarone has a very desirable profile, if you will, in that it can act like all 4, the 5th class tends to be a mixed class, but the major 4 antiarrhythmic categories. It can act as a sodium channel blocker like the class 1 antiarrhythmics. It can act like a beta blocker like the class 2 antiarrhythmics. And it can act like a class 3 antiarrhythmic in that it blocks potassium and calcium channels both. And then, potassium and sodium. And then for the 4th class of antiarrhythmics, the calcium channel blockers, it can act as a calcium channel blocker. And we'll cover that as well as we go along. Your takeaway from this lecture is going to be pretty simple. Amiodarone is gaining a very popular base of physicians and EMS systems. It's used for many of the arrhythmias that are out there. It's largely replacing adenocard, which is adenosine, lidocaine, and cardizem, especially in systems that have cost issues. You want to keep your overhead limited as possible. So if you can take away adenocard and lidocaine and cardizem, you're saving 3 drugs for the price of 1. And that amiodarone is not very expensive. More importantly, cardizem, as perhaps some of you know that run on ALS rigs right now, cardizem has to be refrigerated. And so when we take that out of the mix, And of course, a lot of systems are moving away from succinylcholine. We start seeing that the only thing really left to refrigerate is going to be the Ativan. And subsequently, with Versed replacing that largely through the atomizer devices, we could very well eliminate the refrigerator altogether. For fire departments, that would mean no refrigerators on the engine companies, because many of these drugs inactivate over 95 degrees Fahrenheit. And so on a hot, especially down here in the South, a hot Texas day, you leave your drug box in the apparatus bay in one of the engines, you can lose half your drugs within 24 hours. So in any event, the amiodarone is going to be a larger player over the next couple of years, as you will see. And subsequently, with the National Registry telling us now that there's going to be many more questions available on the test bank, it has to do with the amiodarone, not so much with cardiac arrest, but as well as SVT and arrhythmia management. So with that very long-winded introduction, let's get started. So you know that supra, above the ventricles, SVT, the patient, you can't really tell where the arrhythmia is originating from, supra, above the ventricle. It could be anybody but the SA node. The SA node obviously would be a sinus tachycardia. But when you've got multiple foci firing, or if you've got an irritable focus firing at a very high rate, you have a supraventricular tachycardia. And what distinguishes these type of arrhythmias from the others is what they can contribute to. SVTs, especially atrial fibrillation with a rapid ventricular response, SVTs can contribute largely to strokes. The atrial fibrillation, the most popular, if you will, or the most notorious of all the arrhythmias when it comes to non-lethal, but very, very, very bad producing disease effects, is the one that's the quintessential arrhythmia that you have to learn, where the patient is actually still alive and you have to do something quickly. Also, you recognize that atrial fibrillation is a major contributor to stroke, as well as mesenteric ischemia, mesenteric infarction. And let me say that again, because you're going to see that on the National Registry, at least one question, is that atrial fibrillation, by virtue of the fact that it forms clots in the atrium and then kicks, all of a sudden, you may have a couple of normal SA node type beats that will kick the atrium and send the clots on their way. And they can go one of a couple of ways. They can go to the brain, they can go back down into the heart, cause a heart attack. Obviously, when they go to the brain, they cause a stroke. They can shower. In other words, as they go through the aortic valve, they shatter into a gazillion pieces and goes up into the brain. And now you've got, let's call it 100 small clots that are up there in the brain vessels. And you get a patient that looks like they're having a big old stroke. The big clot may go into the middle cerebral artery or the anterior cerebral artery and cause motor, facial weakness, speech issues, can't move your arm or leg, that kind of thing. But a lot of little pieces that are flying around as well can contribute to illness as well and extend the stroke even further. So when you get that showering phenomena, they can also shower down into the abdomen, and through the superior mesenteric artery, the clot can travel down the aorta into the SMA, the superior mesenteric artery, and clot off blood supply to the entire small bowel and 2/3 of the large bowel. Subsequently, these patients are usually 70s, 80 years old, with a history of atrial fibrillation, where they have sudden onset of abdominal pain. And next thing you know, you've got an acute abdomen, or somebody who will die of a mesenteric infarction. In other words, the entire bowel dies. And of course, what's in the bowel? a lot of bacteria. So when the bowel dies, bacteria escapes and you have yourself a fatal situation. So another long way of saying supraventricular tachycardia represents all that's bad with the world. And it's going to be your responsibility as a paramedic to recognize when these arrhythmias start getting bad and what diseases they're contributing to. Keeping in mind that even an abdominal pain in a 60, 70, 80-year-old patient or older warrants an EKG. You're going to be looking for these kind of atrial fibrillations. So when you have a supraventricular tachycardia like I have thrown up here right now, you can see that it's basically irregularly irregular. You can see that it's narrow complex, and narrow complex would be any QRS less than 0.20 seconds in duration, 5 boxes there. And subsequently, when you count something like this, and it looks like a rate of about 160-ish, it's going to be, you can count them all out. It's a 6-second strip, but I used it 300, 100, 50, 100, rough down and dirty estimation of how you get a rate just looking at a small amount of the strip. So here, another supraventricular tachycardia. This rate looks like it's about 170 or so. And again, the QRSs are narrow. They're less than, obviously, 5 boxes. The R to R interval appears to be irregular. In other words, it's not marching out. If you were lining that up with either calipers or with just a piece of paper with marks on it, you'll see that the supraventricular tachycardias, most of the time, more times than not, are the atrial fibrillation type, although you can get what they call AV nodal reentry tachycardia. That's all really cool words for regular rate and, regular rhythm tachycardia. But the supraventricular tachycardia we generally deal with is going to be a pulsed VTach or a atrial fibrillation rapid response. So sometimes when you look at these SVTs, you're like, geez, okay, in this particular case, not too bad. I can see that it's atrial fibrillation. I cannot see a P wave. And the R to R interval as they march out are not marching out directly great. And so you get your diagnosis of irregular tachycardia. So again, there's 3 questions that you have to ask yourself when you're looking at an EKG that shows SVT. And the first is if it's narrow or wide. Second, regular versus irregular. And then the third step is really going to be based on the vital signs that your EMTs or partner paramedics give you and the patient's mental status. Altered mental status plus irregularity plus narrow or wide. And you're going to be treating your patients with at least amiodarone and maybe even cardioversion. So it really all comes down to, or it narrows down to, the 3 steps. And then what are we going to do for it? Because all 3 of those steps are going to tell you what the next appropriate treatment is going to be. Anything unstable, for the most part, gets electricity. Although I want you to be aware on the National Registry that amiodarone could be listed as one of the answers for an unstable SVT. For the most part, on the National Registry exams, you're going to see cardioversion as still being the treatment of choice. But if the cardioversion doesn't work, then we may be forced to use an amiodarone. Again, cardizem, adenocard, some of the other antiarrhythmics, lidocaine, cannot be used in unstable arrhythmias because they'll make the hypotension worse. But for some reason, amiodarone does not, and we'll take it. So, what does your neurocomplex supraventricular tachycardia look like? Well, when you're looking for AV nodal reentries and when you're looking at multifocal atrial tachycardias and such, you're going to see the, you're going to see the P waves, and we'll go to it here in a little bit. So if you'll list these out for me, that would be great. P waves, sinus tach, AV nodal reentry tachycardia, atrial tachycardia, multifocal atrial tachycardia, and don't worry too much about the last one, you're not going to see it. So sinus tach, AVA NRT, atrial tach, multifocal atrial tach, those are going to be the big ones that are still showing you P waves. And if you're showing P waves, then the QRS more likely than not is going to be neurocomplex. Now, if the P waves are after the QRS complex, then we may have an AVA reentry tachycardia. You see that here as well, depending on whether it's high in the atrium or low in the atrium. Now, we may be getting into the weeds on this a little bit, and I want to assure you that we're talking about this from the standpoint of background. AV nodal reentry tachycardias are not tested on the National Registry, so don't worry about it. But any tachycardia gives you a heart rate over 150, you have to be thinking supraventricular tachycardia, because the SA node can't fire any faster than 150. Okay, so atrial flutter with a 2-to-1 conduction block can be mistaken for a sinus tachycardia, but again, the question becomes is how do you treat it? And the answer is generally we don't. You leave those alone. So what are we going to focus on in the National Registry? Okay, time to pick your pens back up again. Here we go. When your patient has a heart rate here, in this case 150, you have to ask yourself, what's blood pressure? What's the respiratory rate? Is the patient having altered mental status? If they are, this is going to indicate either your cardizem or your lidocaine or your amiodarone, depending on what system that you're in. Most of the time, cardizem is tested on the National Registry, but like I said, we're transitioning now to amiodarone. So you may see it either way. The key in these type of managements is to determine whether or not they're unstable, which means altered mental status, low blood pressure, shortness of breath, difficulty breathing. If I sound repetitive, it's because these are very important concepts that you have to know for the National Registry. They're tested. So be watching for your altered mental status patient or your patient with the 90/50 blood pressure who's running an SVT greater than 150. You're either going to be looking at cardioversion or less likely amiodarone. Now, switching gears, we go from the narrow complex tachycardias, in other words, the QRS is less than 0.20, and we move it now to the wide complex where it's greater than 0.20. Now, these wide complex tachycardias can be ventricular tachycardia, or it can be a regular looking supraventricular tachycardia with a block. Now, you may say, geez, no wonder everybody fails cardiology on the National Registry. Yeah, it's the single most failed subject. Most failures on the National Registry occur because of cardiology. The reason why I'm giving you these focus slides is one, I'm one of the people that write the questions for the National Registry. Second is, this is a recurrent topic that you'll see in the field. And so common things happen commonly. More often than not, your tachycardias are going to be neurocomplex, but you are going to see ventricular tachycardias that have a pulse, or you may see a supraventricular tachycardia, which looks to be fairly regular. It's firing so fast you can't tell if it's irregular. Subsequently, you then switch into the mode of, gee, are you stable or are you unstable? If you're stable, you're going to get amiodarone or cardizem. If you're unstable, you're going to get cardioversion. Less likely amiodarone, but again, watch for it. So the wide complex tachycardias tend to be more pathognomic for electrolyte imbalances or for electrical system problems. So your left bundle branch blocks will look wide. You know, if the patient gets tachycardic, it may look like a wide complex tachycardia. And it's the same thing with the left bundle branch blocks, in that they're wide from a standpoint that the left anterior and left posterior fascicular branches are blocked, and subsequently the only thing that's really beating these people is the right bundle. Subsequently, your wide complex tachycardias can be the most lethal of them all, because it won't be long before badness happens as a result of it. Your renal dialysis patients, your patients that have high potassium, as the years go on now, you're going to be seeing eye stats and other laboratory measurements in the back of the rig. And the paramedics are going to be expected to know what everything looks like in various situations. The eye stat, as you draw blood, isn't going to give you a result for about 90 seconds to 2 minutes. Subsequently, an EKG can be performed, and if you see a wide complex tachycardia with a altered mental status, then look at your eye stat. If the potassium is sky high, then you probably need to be given calcium chloride or sodium bicarbonate. That's the same thing if they have tall peak T waves. And we'll get into hyperkalemia when we come to metabolic disorders later on this year, as we continue on the lecture circuit for cardiology and endocrinology emergencies. You'll find that potassium plays a major role in all that as well, and it can cause a wide QRS complex. All right, so torsade is a peculiar type of ventricular tachycardia. It tends to be unifocal, almost it looks like it's coming from one area, and then all of a sudden it looks like it twists, and then it looks like it's going the other direction. So you got a bunch of upright beats, and then you got the squiggly line in the middle, and then you got a bunch of down beats. Now, when you see the up, the squiggly line, and then the down on an EKG strip on the National Registry, be thinking torsade. Treated the same way as the other ventricular tachycardias, because it is a ventricular tachycardia, but it's from multiple sources, and it's kind of an interesting arrhythmia. You don't see it very often, but when you do, it's actually a very good academic exercise. And of course, torsade generally degenerates into ventricular fibrillation, so your call is your patient's about to get very exciting for you. Okay, so here's an example of a wide complex tachycardia. Focus on V1, V2, V3 here, and that's where most of them are going to be diagnosed from when it comes to the right bundles. V4, V5, V6, especially V5, V6 can be your left bundles, along with 1 and AVL here. But in this particular case, you can see in V2 and V3 how wide they get. And subsequently, a wide complex supraventricular tachycardia can almost look like anything it wants to. This is, again, a wide complex supraventricular tachycardia. This is not VTAC, but you can tell that if you're just got one lead hooked up and you're looking at something like this, like you're seeing in V2 or V3, you could very well call that VTAC. Now, this is where it gets dicey, because one of them calls for one medication and VTAC can call for another medication. If you give lidocaine in a wide complex supraventricular tachycardia, you can throw them into cardiac arrest. If you give cardizem for a VTAC, you can throw them in the VFib. And so it becomes very important for you to make sure that you get a clear understanding, clear reading, the difference between a wide complex supraventricular tachycardia and then a regular tachycardia, a tachycardia that's associated with a pulse. Obviously, if there's no pulse, I would just move into pulseless VTAC and call it a day and run your algorithm there. But for patients that do have pulses, although they won't for long, distinguish between the two. Now, I mentioned amiodarone earlier about 80 times. And the reason why I mentioned amiodarone is because amiodarone can take the guesswork out of all of it. In other words, if I give 150 milligrams of amiodarone over 10 minutes, and it turns out to be VTAC, the patient's VTAC will come under control because it's a class 1 antiarrhythmic, sodium channel blocker. That's usually the problem that we have with the VTACs. Now, when you look at this rhythm that I'm showing you up on the screen right now, a wide complex supraventricular tachycardia, and you give 150 milligrams of amiodarone over 10 minutes, it will convert the supraventricular tachycardia. In other words, amiodarone is safe in both types of arrhythmias. Whereas if this is a lidocaine cardizem system and you get them confused and you give the wrong medication, and I'm not talking about 2 in the afternoon on a Wednesday when you're alert and awake. I'm talking about 4 in the morning, usually when these people call you. If you give the wrong medication, you throw them in the VFib. And then there's, a lot of embarrassing questions and a report and a really pissed off family. And of course, state agencies may get involved as well. So in busy systems, and I have a busy system up here in Sherman, Texas, I'm helping them take the guesswork out of it. If they have one of those confusion strips, that could be either wide complex supraventricular tachycardia, or if it's a VTAC with a pulse, the amiodarone is going to be indicated. Why? You can't kill them. If they do die as a result of the amiodarone, then it was because the patient had an ischemic heart and was having an MI at the same time, and there was just nothing that's going to save them. But you can't give the medication and make a mistake. Okay, the third type of VTAC, there's a regular wide complex VTAC, there's a multifocal ventricular tachycardia, or what they call polymorphic, and then there's the torsade. And your prolonged QT intervals. Now, let's talk about that from the standpoint of your national registry exam. You keep hearing people say, well, could prolong the QT interval. Don't give this drug because it could make the QT interval longer, which makes it worse. And then you may ask yourself, well, gee, okay, so the QT interval gets long. What's the badness that occurs with, hello there, how are you? I have a grandchild here. The prolonged QT interval can develop into VTAC. So whenever your QT interval gets so long, or if you're on a medication that can prolong it, or as you're looking at the EKG and it says prolonged QT interval in the setting of chest pain, shortness of breath, difficulty breathing, I mean, you got the EKG for some reason, right? That prolonged QT interval puts this patient at increased risk for torsade or for a polymorphic ventricular tachycardia. So one more time, ask yourself, gee, why does everybody keep saying that it's going to prolong the QT interval? What does that mean? What's it going to do? This is what it means. This slide, prolonged QT intervals, giving medications that can prolong the QT interval, or any medications that the patient is already on where they have a prolonged QT interval, puts the patients at risk for ventricular tachycardia. So you're going to have to be on your game. You're going to have to be watching for this and know that torsade or VTAC is the badness that comes from prolonged QT intervals. Okay, so you got that twisting complex, and I've got it here on this particular slide here, where the beats look like they're down, 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 then they kind of twist around themselves, and then they come up, 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 and then they twist and they're down, down, down. So you kind of get this feeling that it's a torsade twisting type of thing. And when I say polymorphic, morphology means what does it look like? And if everything morphologically looks the same, it means that they all look the same. That's morphology. And when they don't look the same, that's polymorphic. In other words, they all have their own different shapes and characteristics to them. And when you see a mess of an EKG like this, until the patient straightens out here at the end, when you see this whole mess in the middle here, you're going to know that it's torsade. If it looks messy, it's torsade. So back to the description now. When do these people start calling 911 for you to respond? They start calling because they're having palpitations, shortness of breath, difficulty breathing, near syncope. Okay, when you get that, oh Christ, we're going out for another 80-year-old who's lightheaded and dizzy and fell down. And then they hand you a bag full of their medications. Okay, which one of these can cause a prolonged QT interval? Probably all of them. And in combination, probably all of them. So your patient deserves an EKG, because if your QT interval is long, your patient's syncopal episode was probably due to a run of ventricular tachycardia. I'm going to emphasize that again because this is an actual question on the National Registry. If a patient is older, 70s, 80s, 90s, 1,000 years old, and they start having dizziness, lightheadedness, they pass out or they felt like they were going to pass out, all of a sudden they started getting real lightheaded. Don't blow it off as labyrinthitis, say, here, take 2 meclizine and call me in the morning. Okay, these patients, when they have the presence of a QT interval in the presence of dizziness, lightheadedness, syncope, near syncope, they probably had a run of VTAC. Okay. So there's your torsade. Now we get into amiodarone. And what does amiodarone help us with? The reason why I'm focusing on the wide complex tachycardias here, the neurocomplex tachycardia, is to let you know that in the case of amiodarone, you're going to start seeing this medication substituting for some of your other medications. And subsequently, amiodarone on this cycle is going to be tested much more than it has been in the past. Amiodarone in the past has been confined to 300 milligram bolus after the first epinephrine for cardiac arrest, because it can electrically convert VFib VTAC, pulseless VTAC. Now we're seeing it for arrhythmia control. So amiodarone has been around for a gazillion years. It is one of the top medications in the world that if you're caught on a desert island someplace and you only got to have the most essential of all your medications, amiodarone is part of it, along with the aspirin and Tylenol, obviously. It blocks potassium channels. It blocks potassium from going into the cell before the next contraction of the heart. Therefore, it'll slow down the heart rate. Potassium, for a heart to beat, you got to depolarize it. To depolarize it means potassium goes into the cell. It's going into 100 million cells at the same time. Nice synchronous beating of the entire myocardium. And it relaxes. When it relaxes, the potassium's pumped out of the cell. Sodium goes back into the cell. And then when we start for the next beat, depolarization occurs when potassium rushes into the cell and sodium is pushed out and back and forth. Well, if your heart rate is going 160, 170, 180, we need to block some of that. Well, sodium moves in and out pretty easily by itself. That's not going to help much in many of these arrhythmias. So we got to block the potassium. And so the potassium is blocked through the sodium potassium ATP pumps that move electrolytes in and out of each cell. and works very quickly. Obviously, if you're beating 160, 170 times a minute or higher, it's working pretty hard. Those pumps are really cooking. Subsequently, by blocking them down, you slow down the rate at which potassium can get into the cell, or you're blocking down what they call fast potassium channels. And so the slow potassium channels are still working, but at least now you've got a heart rate that's 80, 90, such like that. So amiodarone is bolus at 150 milligrams over 10 minutes. And because it doesn't really drop the blood pressure, or make rhythms worse, your blood pressure is going to improve. Anytime you're over 150, cardiac output goes down. It goes down because the heart can't fill that fast. I mean, it's expected to push, 100, 150, 200 mLs in an adult for every beat. And if you're beating 180 times a minute, you'll be lucky to get 50 mLs around, and then you are going to get lightheaded. Then you are going to be unstable from the standpoint of altered mental status or low blood pressure. So it's a class 3 antiarrhythmic, slows conduction rate, prolongs the resting phase of the SA and the AV nodes, and it acts as a beta blocker and a sodium channel blocker and a calcium channel blocker. And yet, at the same time, in studies, we show that amiodarone can sometimes cause bradycardia or torsade. So for the very rhythm that we're trying to treat here, torsade, we can also, during the course of regular administration to knock down an SVT, we could throw the person in a torsade. This is not a benign drug. It's not a safe drug. It's a drug that we give to licensed paramedics who are fully trained in the use of amiodarone, knowing what to be watching for in the event things go south on you. So when you give amiodarone to an SVT or a wide complex tachycardia and your patient then goes into torsade, okay, we know that this is one of the side effects of amiodarone. It doesn't happen very often. As a matter of fact, it's considered a rare event, but it can happen. So when you make a decision to use amiodarone, of course, it has a higher benefit profile than it does a risk profile, but still just know that it can also cause torsade VTAC. So it's best place that it works, AV node, perfect. It slows down these slow potassium, slow sodium, fast potassium, fast channel sodium channels in the AV node. And as a result, it slows the impulses going through the AV node. Usually it takes 1/10 of a second in SVTs. It's a Wild West show. It's going through at an incredible speed. And by slowing it down again, you can extend that out to, almost a 1/5 of a second. I mean, it's pretty good. It's pretty good from that standpoint. And replaces the old digoxin that we used to use. Digoxin, digitalis, would work at the AV node by actually poisoning the channels within the AV node. And subsequently, we don't feel good about the word poison to begin with. So we don't want a permanent destruction of anything. If we can temporarily block something, we'd rather do it that way, and the amiodarone is perfect for that. So it's given 150 milligrams over 10 minutes, and then typically we start at 33 milligrams an hour. Now, when we talk about the drip, and I tell my paramedics this too, amiodarone, you give 150 milligrams over 10 minutes, do you really have to worry about a drip? You do if you're running rural or frontier areas where your travel to the hospital could be upwards of an hour. Then you may want to start your drips. Lidocaine has a half-life of 33 seconds. Adenocard has a half-life of 9 seconds. So lidocaine, you have to give a push, 100 milligrams, and then you give 2 to 4 milligrams per minute because lidocaine will wear off within the first 30 to 33 minutes. Now, amiodarone is great from the standpoint that when you give it, it has a half-life of about 58 days. So if you can't get to the hospital with your patient in less than 2 months, I tell my paramedics not to really worry about the drip. Know the drip from the standpoint that it's 33 milligrams an hour. Know the amiodarone that it's 150 milligrams over 10 minutes. And there's a good chance you're probably going to be at the hospital if you're running in a municipal area or a urban area where they got a hospital every 2 blocks. But for you good folks that are in some remote areas of the country, your amiodarone drip, just like your lidocaine drips and other medications that require drips because they have shorter half-lives, is going to be very essential. Now, from an ER standpoint, we place patients on amiodarone drips because we like to wean patients off. So we'll start them at 33, and within 24 hours, they'll be down to 10 and then 5 and such. Even though it's got a half-life of 58 days, its effective time of working is about 48 hours. So I mention this from the standpoint that one other badness about the amiodarone is that it has the bad characteristic of causing pulmonary toxicity. Amiodarone is bad for the lungs. And so a patient who's already got bad lungs, such as a COPD or a chronic bronchitis patient, less so with asthma, you're going to start seeing some stiff lungs. And the last thing a COPDer needs is another cigarette or amiodarone. And subsequently, the amiodarone can be a little dicey in patients who already have pulmonary issues. But most importantly, about 10% of the population, and in some studies, if you read them, up to 17 to 20%, can have pulmonary toxicity develop as a result of amiodarone. Now, what does that mean for you in the field? If the patient's dying of an arrhythmia, give the amiodarone, get them out of danger. We'll deal with the pulmonary toxicity later. If your patient's already on amiodarone at home by mouth, and you're called because they've got an SVT or something, in that particular case, you may want to go to your lidocaine or an alternative medication because more amiodarone isn't going to make this happen unless the patient has been non-compliant. If they've been non-compliant, they haven't been taking their medications like they're supposed to, the amiodarone will help them. But if they swear to God that they've been taking their medications every day and they still go into SVT, then from a field standpoint, you may want to consider another medication such as the lidocaine or the cardizem. But nature of this lecture and the introduction of the questions this year and the 2020 cycle of the National Registry has to do with the dosage of amiodarone for arrhythmia control. Arrhythmia control, uncontrolled rapid response atrial fibrillation, multifocal tachycardia, torsade, polymorphic any one of the other polymorphic tachycardias. Anything that has a heart rate over 150 that is also associated with altered mental status, amiodarone is going to start taking the first banana spot. It's going to be taking the first drug of choice spot. And so it's going to be imperative to know that the 300 milligram amiodarone for the cardiac arrest is for resuscitation, yet the 150 IV over 10 minutes and 33 an hour is going to be for arrhythmia control. And again, you're going to be seeing more and more of this. Okay, I just wanted to make it a focused lecture on the SVTs as they relate to the National Registry exam. What I gave you in these 17 slides covers everything that you're going to need to know for the National Registry when it comes to the supraventricular tachycardia, the SVT, and amiodarone use. Does anybody have any questions for me?
Let's start at one at a time here and see if everybody's still here first. Marilyn, are you still here? And if so, do you have any questions for Dr.?
Hello, can you hear me?
Yes.
So can you just, you said the 300 milligrams IV bolus is for resuscitation and the 150 over 10 minutes is for?
Arrhythmia control,
Okay, thank you.
anti-arrhythmia.
That's all, thank you.
No, that's fine.
Rebecca, when did you sneak in here? I just now saw you pop in.
I was 4 minutes late.
Okay. do
Sorry
you have
about
any
that.
questions?
No, ma'am.
All righty. How about Benjamin?
No questions, doctor. Thank you.
And Michael?
I have no questions either. Thank you.
Hey, Michael, I noticed you listed yourself as 300E. You're in 400C now. You're in with the big boys and girls now. So I just wanted to make sure I gave you credit in the right place.
Okay. Yeah, I just haven't had time to change it yet. But yeah, I know. I forgot to change it.
That's okay.
That's
All right, Lewis,
Yeah.
how about you?
Hi, Dr. Frame. The only thing I maybe had a question is if our patient, say, presented with the wide complex tachycardia and were hypotensive, I would assume we wouldn't give the amio at that
Yeah.
point.
Yeah, actually you would. Now, even though amiodarone can cause hypotension, it has the indication for unstable SVT. Unstable SVT can be the chest pain, hypotension, altered mental status. So it's kind of weird that, the medication it's designed to treat by curing the SVT who is hypotensive, by slowing down the heart rate, the patient is no longer hypotensive, but watch out for the hypotension.
Okay.
Yeah, and you're on the right path by saying, yeah, geez, how am I supposed to treat something that I know is probably going to happen? First of all, amiodarone does not cause hypotension a lot. I've seen it rarely. And if I can get that hypotension corrected by slowing down their heart rate, getting it below 150, so that their ventricles can fill with blood so that they can maintain their blood pressure, then we've achieved our goal. Just have to watch out that
So the reward would be greater than the actual, I guess, I mean, like, everyone says, treat your patient, monitor, and then just base it off of that.
Yeah.
Okay.
You summed it up perfectly. It's risk-benefit ratio is in favor of using it.
Gotcha. Okay, that's all I have. Thank you.
Great. How about you, Linnea?
No questions, but thank you.
All right, let's see. And I think Pratish, you're here. What about you?
Oh, hi, Professor. How are you doing today? I have a
Good.
question. It's about a patient being unstable. So unstable means if you have any chest pain, shortness of breath, hypotension, or confusion, right?
That's correct.
Do we need to have like one of these criteria with the arrhythmia to consider unstable, or does he need to have two or multiple of this with arrhythmia to consider unstable and hence go forward and cardiovert?
Yeah, you only need one.
Okay.
Most of the time, it's going to be altered mental status.
Okay, gotcha. All right, thank you. Yeah.
You're welcome.
I miss anybody? I don't guess so. Nobody's jumping in here, and I think I got everybody. Well, Dr. Frank, I think we've got another one under the books. So thank you so much for your time tonight, and I've already given everybody your credit inside the EMS testing grade sheet for you. You guys remember we have spring break next week, so you won't be able to find most of us. I don't know about chat rooms on Monday and Tuesday night. Just watch the chat room calendar to see if they're posting or not. So they'll put something out on there. Otherwise, you guys have a great spring break, and we'll see you soon.
All right, very good.